Welcome to Frankly Speaking About Family Medicine, a CME podcast series where each week we translate today's late-breaking clinical research and news into tomorrow's practice. I'm Frank Domino, professor in the Department of Family Medicine and Community Health at the University of Massachusetts Medical School and editor-in-chief of the 5-Minute Clinical Consult series. Be sure to visit Pri-Med.com/podcast after the discussion for more information about today's article and to claim CME CE credit. Jeremy, a 63-year-old patient with atrial fibrillation, has been on apixaban without problems for the last 2 years. He is scheduled for elective cataract procedure and is in today for a pre-op evaluation. The ophthalmologist tells him to ask you about how long he should stop his anticoagulant and if he needs bridging heparin around the surgery. You remain uncertain about the best advice to give him. Hi, this is Frank Domino, and joining me today to talk about preoperative evaluation for patients on blood thinners is Dr. Robert Baldor, professor and founding chairman from the Department of Family Medicine at UMass Medical School, Baystate in Springfield, Massachusetts. This is a great topic, Bob.
Hi, thanks, Frank. Glad to be here and to talk about it. I actually wanted to bring this forward because there's a new study out. It's the PAUSE study. And this was a cohort study conducted at 23 clinical centers in the US, Canada, and Europe. They looked at data from 2014 to 2018. A PAUSE, by the way, stands for the Perioperative Anticoagulation Use for Surgery Evaluation. And this was a cohort study. And they were looking at patients, there were a little over 3,000 of them, scheduled for elective surgery or procedure, had AFib, also taking a DOAC, apixaban, dabigatran, or rivaroxaban. But your patient's on apixaban. These were enrolled in a simple standardized what they called a perioperative DOAC therapy intervention, interruption and resumption strategy. And so it was based on a specific agent that people were on, and whether any associated bleeding risk for the procedure, whether it was at high risk or low risk. And they also looked at creatinine clearance because we know these agents are affected by renal metabolism. Now, the main outcomes they were looking for was major bleeding or thromboembolism, right, which is arterial thromboembolism, which is why people are on these things, looking for strokes, systemic embolisms, or TIA. And so they came up with a standardized approach.
I like the idea of a simple standardized preoperative approach with these agents, Bob. Can you give us the specifics?
Yes. So this study that they looked, again, the PAUSE cohort study, mean age was 72 years, plus or minus 9. 66% of these folks were male, and they had 3 cohorts based on which anticoagulant they were used. Almost 42% were on apixaban, 22% were on dabigatran, and 36% were on rivaroxaban. So the patients were excluded if they had a creatinine clearance of less than 25, or for that was for the apixaban users, less than 30 for the others, or if they had cognitive impairment or a psychiatric illness or more than one procedure scheduled in the next 30 days. So before the procedures, though, the patients were categorized as having high or low bleeding risk according to a classification system, which is pretty standard. And so I think probably we could do is we could append this to this podcast, Frank. But for example, a high bleeding risk would be if you're having a major thoracic surgery or intracranial surgery or significant, you had an endarterectomy, hip arthroplasty, those type of things. Low bleeding risk, though, was your patient you mentioned having cataract surgery. That's considered low risk. Having a colonoscopy, low risk. Pacemaker implantation, dental extractions, those were considered low risk. But they really wanted to make sure that in this study that they had at least a third of the patients that were involved were undergoing high risk procedures, and that was seen. So before the procedure, they were advised to stop taking the DOAC 1 day before a low bleeding risk procedure or 2 days before a high bleeding risk procedure. After the procedure, you would resume your regimen 24 hours after a low bleeding risk procedure, and 2 to 3 days after a high bleeding risk procedure. Again, assuming that hemostasis from the procedure was what was achieved.
Oh man, is that simple and straightforward? 1 day for a low risk procedure, 2 days for a high risk procedure, and then resume for low risk procedures within 24 hours or 2 to 3 days for a high risk procedure. Boy, Bob, this is terrific. So, how did they go about assessing risk? I mean, some patients are old, some patients have other comorbidities.
Yeah, you're absolutely right. The guidelines interesting for heparin bridging suggested assessing all of this, but they did not. They were looking at a simplified method to be used without, by the way, without heparin bridging. So they assessed bleeding risk just based on the procedure, as I noted, but not for clot risk. Although they did note if you had a patient that was at high risk for a DVT, for a venous thromboembolism, and I'm assuming that's somebody who's probably immobile and so on, they could receive a prophylactic dose of heparin after the operation until the DOAC therapy was resumed. But they said, don't bother doing any of this. We just want to look at a simple approach. Low risk procedure, you stop a day before, you start a day after. High risk bleeding, you stop 2 days before, you start 2 days after. That was the idea behind this simplified approach, is don't do any of those things.
Okay, great. So now they've got this approach. What were the outcomes?
Yeah. Well, I think it was really pretty neat. In secondary analysis of patients who were adhering to this therapy and assumption, the post-op, the 30-day post-op rate of major bleeding was 1.2% in the Abaxaban cohort, 1% in the Dabaxaban cohort, and a 1.69% in the Rivaroxaban cohort. So really low risk here for bleeding. But of course, the thing is we're concerned about is, well, what about thromboembolism, right? But the rate of that was very low too. It was 0.19% in the Abaxaban cohort, 0.5% in the Dabaxatran, and 0.4% in the Rivaroxaban cohort. So they concluded that in patients with AFib who are receiving these agents and required interruption of the anticoagulant regimen for elective surgery or procedure, a simple standardized approach that we just talked about that does not require the use of heparin bridging or any perioperative coagulation function testing being done, it was associated with a very low rates of perioperative major bleeding, all less than 2%, and low rates of arterial thromboembolism, less than 1%. And so you can compare this to the bridge trial, which was the one that talked about the bridging for patients and using warfarin therapy. Those who were not bridged had a 30-day post-operative major bleeding of 1.3% and a arterial thromboembolism rate of 0.4%.
So essentially no real difference.
Yeah, this is exactly what we're seeing. So overall, it looks like patients with AFib and who are on one of these agents, you can simply stop this for these elective procedures and don't worry about heparin bridging, don't worry about testing. Your assessment is what's the risk of bleeding from that procedure. If it's low, stop a day before, start a day after. If it's high, stop 2 days before, start 2 days after. Again, assuming that they're not having ongoing bleeding from their procedure. And then that little caveat in there: if somebody's at risk for DVT, again, we're not talking about an arterial thromboembolism, which is the reason for the anticoagulation. But if they're otherwise at risk for DVT, yeah, go ahead and give them as you would treat anybody for post-op, prophylaxis.
Thanks so much, Bob. Really interesting paper, really practice changing and informative. Practice pointer. In patients with atrial fibrillation, DOACs can be safely interrupted for elective surgery or procedures using a simplified standard perioperative management style without heparin bridging or measurement of coagulation. Join us next time when we discuss outpatient management of musculoskeletal neck pain. Thank you for listening to Frankly Speaking About Family Medicine, brought to you by Pri-Med. To claim credit and receive additional information about the article referenced in today's episode, visit primed.com/podcast, and see you next week.